Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase them all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this week's episode, we are going to be jumping in to a new CEU episode.
Get it? Jumper's knee?
Yeah, that's why I did it. It's for the jumper's knee.
I was about to say jumper's tendon.
I mean, yeah, that works. That could be a new one.
You heard it here first.
We coined a new one.
So as Randy said, this is a CEU episode. So if you're listening to it as it comes out, which is right before reporting period, this is good for a Category A CEU. Please check the show notes below to figure out how to get your certificate. But thank you so much to Clinically Pressed and Athletic Training Chat who put on this CEU. The CEUs, our latest 5, the way we do it, the latest 5 are free. The rest are affordable, very, very affordable. And proceeds go to support the show as well as donate ice tubs for athletic trainers. And we've already been able to secure a couple of those. So we're super excited about those. Mm-hmm. Thank you so much to Joel Ludke for putting those together. He is a force in this profession.
Yeah, absolutely.
So again, down in the show notes, and then also if you're interested in the references for this episode, we have those on our website as well.
Yep.
So what are we talking about today, Randy?
So like we said, we will be talking about Patellar Tendonopathy, or also known as jumper's knee, because, all the jumpers seem to have problems with this. Mm-hmm. We're going to discuss some possible risk factors for the development of patellar tendinopathy. We'll analyze the consequences of patellar tendinopathy on the motor system. And then we'll analyze the effectiveness of intervention techniques on treating patellar tendinopathy. So no musculoskeletal injury episode is complete without something anatomy related.
Duh, we have to start with that.
So luckily we'll keep this one pretty quick because there's really only so much you can talk about when you talk about the patellar tendon. So the patellar tendon, which is pretty interesting in some textbooks, they'll actually refer to it as the patellar ligament.
Oh, I have heard that before.
Right? So if you see it, it is technically the same thing. It's pretty much...
Is it because it's like technically bone to bone?
Yeah.
Because the quad tendon versus the patellar ligament?
Yeah. I mean, there are some... Yeah, no, for sure. But there are some connections from the quad tendon that kind of branch out into some of the patellar tendon. But for the most part, the patellar tendon is coming off that inferior pole. So that's probably where you get like the ligament designation. And then obviously from the inferior patellar pole, it inserts into the tibial tuberosity.
So if we classify that as a ligament versus a tendon, then technically some of the properties change as well. Because ligaments heal differently than tendons.
That's true, but I think the histological makeup is still fairly similar to a tendon.
Yeah, okay. So I'm not going to call it a ligament.
Yeah, I wouldn't either. I feel like if you did that in real life, people would be like, huh? Yeah.
It's like calling the a bone in your hand the navicular, when most people know navicular is arch.
that's wild. Yeah. Or like the malleolus.
Never say that again.
So, like I said, this tendon does come from the quadriceps muscle group. So it's going to provide knee extension, right? That's what the quads do. That's their job, baby. Just powerful knee extension. What I thought was really interesting, and I feel like we don't really talk about this in school, was the force that's created to actually produce knee extension is actually shared between the quad tendon and the patellar tendon. I feel like we always talk about patellar tendon. We don't really talk about the role of the quad tendon.
No one talks about the quad tendon until it gets injured.
Yeah. Yeah. It's the
stepchild.
Yeah, it's the stepchild of knee tendons. So from about 0 to 45 degrees of knee flexion, because you got to think of just the bend in the knee, force is predominantly being focused over the patellar tendon, in particular the inferior pole. Keep that in mind when you start thinking about your athletes with patellar tendon pain.
Inferior pole is an inferior part of the tendon?
Of the patella.
Oh, okay.
Yeah.
Inferior pole of the patella.
Yes.
So force is mostly on the bottom of the patella.
Yes,
at the beginning of knee flexion.
Yes.
Okay.
And the reason for this is because that 0 to 45, the actual quadriceps tendon has more of a mechanical advantage. Mm-hmm. So it doesn't need a lot of force like going through the tendon to actually produce movement. So it's more efficient that way. So if you keep that in mind, 0 to 45 tends to be most athletic things like running, jumping, right? We're not going into 90 degrees of flexion. Like,
You're not like Rasputin.
yeah, exactly. No. Right. So there's a lot of force going into the patella because it's not at a mechanical advantage. So it has to work harder in order to produce a knee extension.
So that's why patellar tendon strains happen
Exactly.
at the inferior pole.
Exactly. Once we go above that 45 degrees, now it switches. The patellar tendon now has more of the advantage and doesn't take on as much force as the quad tendon would. Mm-hmm. So just keep that in mind as you start thinking about your athletes to be like, oh, this is why. So with that said, right, a lot of load is going to be through that patellar tendon while we do our running, jumping, all the fun things. So now that we kind of have that overview of just kind of the anatomy that we're looking at and kind of an explanation about the vulnerability of the patellar tendon, we can now kind of like attack what it is and what are some kind of risk factors that could predispose someone. And there's actually a lot of research on risk factors for patellar tendinopathy.
Oh, I have a love-hate with risk factors of injury.
It's always a grain of salt.
I feel like risk factors are better when looking at return to play to decrease the risk of re-injury.
Re-injury, yeah.
Or I guess reduce, yeah.
Well, that's what I like because like in here we talk about the consequences of injury, which a lot of those studies are retrospective studies, right? You take a group that has patellar tendinopathy, a group that doesn't, and you see what's wrong with them, right? But you can't necessarily say, well, that's a risk factor because it's hard to say, was that there before? It's the whole chicken and the egg problem, right? But like you said, I think that's still important to know because now we know what the deficits are on someone who has it, and let's kind of correct that before we return them to play. So I agree.
I don't think that it's as useful as preventing every single patellar tendinopathy from occurring. I think it's more helpful in the re-injury.
For sure. And I think and we'll kind of talk about it with the risk factors, is highlighting people that we know that they now have a higher risk. Maybe we should do more interventions or monitor those people a little bit closer than just like everybody who may not have that kind of risk factor. So patellar tendinopathy, like every other tendinopathy that we've talked about on the podcast, is just that failed healing process, this time just focused on the patellar tendon, which you can imagine happens quite often because, again, it happens in a lot of jumping sports. I think it was like, what was I reading? I think it was like 37% or like 40 something percent of like volleyball players and like almost 50% of basketball players have been found to have patellar tendinopathy. So again, those are all predominantly jumping sports.
I wonder how much, this is just a tangent off topic, I wonder how much is truly like patellar tendinopathy versus like fat pad impingement
good question.
Or something along those lines, or like chondromalacia or patellar tracking. Or a combination.
Yeah. I think I didn't look a ton into the epidemiological studies of it. A lot of the studies that divided the groups into patellar tendinopathy did confirm patellar tendinopathy via ultrasound.
Okay. That's helpful.
Yeah. I think, like you said, that's a good point about the fat pad. I think that could probably get kind of looped in there sometimes. But for sure, like chondromalacia, patellofemoral pain syndrome, the pain pattern's slightly different to where what they're looking for. So I think we could feel at least a little confident that those people didn't get looped in.
Then adding those, the knee pain is going to go significantly higher.
Significantly higher. Absolutely. And patellar tendinopathy is fairly debilitating. I mean, I'm just thinking about my student athletes and even the history of my student athletes. Like all of them come in like, oh, I've had pain and it's been like years. Like they just kind of rock with it.
Right.
But like it's actually been reported that like 53% of athletes terminate their careers due to patellar tendinopathy. That's crazy to me.
I would like to know more details on this.
Yeah. I would want to understand the concept. I think it's just that case of just, could be performance too, right? Hey, just it affected their performance and they just kind of hit an end of the road at a certain point instead of just being like, the pain's too much.
Right.
Like I said, you do tend to see it in predominantly those jumping sports like basketball and volleyball.
Okay, so going back to those risk factors.
Yes, thank you. So there actually is some fairly weak evidence, but there is some that a lack of dorsiflexion range of motion is associated with the development of patellar tendinopathy.
I believe it because
I would too.
lack of dorsiflexion causes so much going up the chain.
Yeah.
And how your mechanics move in knee flexion and how your hip strength or like you're technically, if you don't have enough dorsiflexion, then your glutes aren't firing properly.
Yeah.
Because you aren't getting that hip extension moment that you used to be getting.
Yeah, for sure. No, for sure. And you got to think too that foot and ankle, what's the first thing that's hitting the ground to start absorbing the force that's going to start going up the chain, right? And I think it was reported that like between like 37, maybe up to 50%, I think I read, the ankle joint absorbs about that much force from the ground.
Wow.
Yeah. So your ankle's already absorbing a ton of force before it even starts going up the chain. And when we talk about force, we're really talking about that like vertical ground reaction force. So basically the force of the ground hitting you back. Thanks, Newton. Equal and opposite, baby.
So not only are you getting force from the ground, but then you are not actively contracting your glutes to move through the gait pattern, which then can also stem. I mean, it goes up and down the chain from there too, because then you can see people with lower back pain.
No, yeah, exactly, right? So like,
and then that can cause like hamstring issues. We're talking dorsiflexion is needed.
Yeah, 100%. Because you got to think, like, if you don't have the range of motion, right? Because like it's like when you try and catch like a ball barehanded. A total athlete right here. I do it one-handed, right? But right, like you like follow the ball as you like catch it, right? So you're increasing that time the force is being dissipated. Well, if you don't have the range of motion to do that, if your ankle like stops immediately when it hits the ground, well, that force is still there and it has to go somewhere, and something else is going to absorb it. Could be the tibia, it could be the patellar tendon, right? Hamstring, right? Something's going to have to absorb it, and where's the weak point? It's now what you're looking for. And there is actually evidence that does support this claim, that lack of dorsiflexion has been associated with higher vertical ground reaction force loads. So again, you're just not absorbing force. Something's going to get blown up.
Right.
Yeah. There is some limited evidence as well that kind of shows knee mechanics while you're landing could also predispose someone to patellar tendinopathy.
Is that mostly because of patellar tracking though?
It's mostly how you absorb. Again, so let's really focus on how you absorb force.
Okay.
So we're talking less knee flexion at initial contact from a jump, less knee range of motion during the movement when you're landing.
Okay.
And increased knee flexion angular velocity.
I was understanding mechanics wrong, but now I see.
Well, no, those would be mechanics, but just not in this case.
Yes. So basically, like if you land without absorbing the shock, then your knee freaking absorbs the shock.
Correct. So basically, yeah, that's a good way of putting it. It's landing too stiff and then not controlling the eccentric phase of landing. So if you just like land and just collapse, basically, right? Like your patellar tendon is going to have to try and take on that load because the quads aren't basically producing the tension to support the tendon. So the tendon's like that.
Okay. I'll think of that next time someone comes in with patellar tendinopathy.
Yeah. Because again, part of the muscle's job is to create tension.
Right.
And in an eccentric way, that tension creates stiffness in the tendon, which should help protect it and make it move efficiently. But if that's not there, the tendon's like going to just go in for the ride, and it doesn't want to do that.
Right.
And then surprisingly, you don't hear flexibility as being a true risk factor anymore that often, but there is some very limited evidence that decreased quad and hamstring flexibility can be a risk factor as well. And essentially, it's increasing that just passive tension on the tendon, or in the case of hamstring flexibility, you basically the patellar tendon has to work harder to create that extension. Because again, you're going against tight hamstrings. Luckily, I don't have tight hamstrings. That's not me.
You don't have patellar tendinopathy either.
That's true. That's fair. I don't think I jump enough to even get that. And finally, and this one I think is probably the stronger of them. That's more opinion based than maybe evidence wise. And this happens in any kind of overuse that we talk about is workload. Right. And there is, again, literature that supports this, right? Greater activity volume has been shown to be a significant risk factor. So that could be like greater volume of jump training, more volleyball sets played per week, so on and so forth. It's basically giving you don't have time for the tendon to repair. And I think also, too, another thing that you look at it is the fatigue aspect, right? If you do more, you theoretically could fatigue. And there is evidence that has shown fatigue has altered jumping patterns in those with patellar tendinopathy. So
Fatigue, man.
Fatigue's a bummer.
Whenever coaches are training through fatigue, like it's obviously necessary.
Yeah.
And endurance is necessary.
Yeah.
But technique after is such a bad idea. And it's always like right at the end. Or I think I saw this study that said if you just determine one thing is like the last run of something, your chance of injury increases.
Oh, interesting.
And I don't remember how much it increased by, so I don't want to spread anything, but it did increase if you say like last run.
Yeah. Ooh, that's interesting. I didn't know that. Well, now that sounds...
I think it's the fatigue, and then I think it's also...
that last-minute effort.
Yeah, because you're like, oh, I'm going to go all in.
Yeah.
And you're fatigued, so you don't have that same...
Interesting. Well, now that actually makes it sound worse, because how many times have we seen coach say, okay, last one, and then 5 drills later, okay, last one. So now you're just created injury.
Maybe that's like more alert fatigue, where they're like, oh, it's not actually the last one.
But maybe that's what it turns into.
Right.
Like, okay, it's not the last one.
I think it's when you self-report last one.
Yeah, okay, that's fair. So along those lines too, of kind of workload, it's actually interesting. Greater jump height. So being able to actually jump higher is a risk factor for patellar tendinopathy.
Well, if you jump off a 1-story building, it's a lot different than landing from a 2-story building.
For sure. Some of that is like that, right? Like obviously you've created the amount of force to jump high.
Right.
But now you need to absorb that force.
Right.
And then also too, another aspect is the people that jump higher, and especially in jumping sports, tend to be pretty good, and they tend to play more. So they're going to have more workload too.
Fair.
All right. So it is a combination of kind of this both. But yeah, jumping off story buildings could do that too.
Yeah.
That would probably be a risk factor for patellar tendinopathy.
Maybe shattering a couple bones too.
Yeah, probably. All right. So
let's jump into the management.
Yeah. So now that we know what could go wrong and what could give this to you, like it's a disease, now we got to talk about what we're going to do about it.
I actually very much enjoy managing patellar tendinopathy.
Yeah?
Yeah.
Is it a good time?
I think you have to, because they're in there all season.
All the time. Yeah, that's true. They are in there all season. When you're kind of evaluating someone with a suspected patellar tendinopathy, there's really not that much that's like fancy and crazy, right? Most of it's done with the history. You just talk to them, you kind of have an idea. Yeah, it hurts when I jump. Okay. And it hurts right here.
One finger.
Yeah. And like possibly some pain with squatting because that eccentric loading. Palpation can help a lot, right? It kind of can help differentiate between patellofemoral pain,
a patellar tendon strain,
Yeah.
or a patellar tendonitis.
Yeah, exactly.
I feel like I didn't talk about patellar tendon strain in school.
No, we didn't.
That was like so bizarre when I think actually you diagnosed that in one of my athletes.
Oh yeah, I was worried about that.
And then I was like, what? I was like, what are you talking about?
Yeah, and then I've had like 2 people. I had one with a partial tear in there, like a strain, and then another one who they reported a patellar tendon strain. I'm like, apparently this is more common than I think.
Yeah, what? It's like when people say they herniated and tore their disc.
That's wild.
Yeah, I was like, what? I've never heard of a tear.
What? That's crazy.
Yeah. It's like I didn't know you could do both, but okay.
Yeah. Maybe the tear led to the herniation. There's a tear now.
That
now the
makes
jelly donut's got the jelly coming out. There are some special tests that you could do to evaluate this. You could do a decline single leg squat. So basically, the patient performs a single leg squat in like a slant board to about 60 degrees. You know, I mean, don't worry, I'm not worried about my athletes doing a full pistol squat and getting down to like 90 and below. So I feel like that, 60 degrees is pretty realistic.
Okay.
And you basically are just
slant
trying
board
to,
is in like toes down.
Yeah, toes down.
Okay.
And you basically just kind of see where the pain's at, right? Obviously, if they do it and they're like pointing at the patellar tendon, you can feel pretty confident it's probably the patellar tendon. But I didn't really find any metrics on that. So, use your best judgment. If it works for you, that's great. There is another test called the Royal London Hospital test, and this one can actually be applied to Achilles tendinopathy as well. Just obviously the way the test is done is at the ankle, not at the knee. But for the knee, you palpate the patellar tendon and knee extension, and they're going to be like, ow, that hurts. Then if you put them into knee flexion, like probably about it's going to be a high degree of knee flexion, and then palpate the tendon, and they're like, oh, the pain's less or it's gone. That would be a positive test.
Okay, why?
That's a great question. I didn't see a great explanation for the physiological aspect of why that might be happening.
I'm just trying to picture this.
It could be just from the initial mechanoreceptor stimulation of the stretch, and maybe that decreases the pain signal. That's the only thing I can think of.
Okay. It's got pretty good sensitivity and specificity.
So that is the kind of the caveat. The one study that I saw on it, it did have pretty good sensitivity of 88%, specificity of 98%.
That's insane. Those are pretty good numbers.
For sure. But again, it is very, very limited evidence. Like, it was a very small sample size. And I think I've only seen one study on it so far. So maybe use some caution before going around and being like, this is the best test ever. Right?
I think you can diagnose patellar tendinopathy without this, but
for sure. But if you need something,
it's a fun trick.
Yeah, it's a fun party trick. Yeah.
Hey, watch this. I can make your pain go away.
Yeah, check this out. Boom. I didn't fix it. I just changed the position real quick. So now that you kind of diagnosed that patellar tendinopathy, especially with the Royal London Hospital test, now we need to understand kind of what happens with someone with patellar tendinopathy. Because again, like a lot of these patients do have it for a long time. Mm-hmm. It tends to reoccur.
Like forever.
Yeah. It tends to reoccur, or they just kind of have different levels of pain throughout the year, but it's always kind of there.
Mm-hmm. And sometimes it goes away and they're like, wow,
yeah,
I can jump today.
Yeah. So there are definitely going to be some adaptations that the central nervous system has decided to do to try and protect itself that ends up being not a great idea long term. Mm. As I like to say, the central nervous system gets all screwed up. Mm. So there is evidence of central sensitization in patients with patellar tendinopathy. So basically what that means is their sensitivity to pain just in general goes up.
Oh.
So they tend to feel more pain.
Oh.
And it could be in other regions outside of the actual patellar tendon. So now they might get more.
That is actually really sucky.
Yes, it is. It's actually a really, really big problem. And it's just how our sensory system changes based on how just that pain signal coming in constantly. Mm. And now you become
I feel like that would be the opposite. I feel like it would desensitize.
Not necessarily, because your body doesn't want to necessarily try to turn off pain. So it's trying to be a signal of danger. So obviously you've ignored that danger. Well, maybe if I spread out the signal, you'll pay attention that there's more danger. So I think that's where it's kind of coming from.
That's fair.
And kind of what we've talked about with some other injuries, and something that was really big in our doctorate program was, okay, now what happens to the motor system when we're in pain, especially when we have joint pain? Mm-hmm. So our pain response does lead to corticospinal inhibition. So this is going to decrease the actual force output from the quads. right? So now it already hurts my patellar tendon. I might have central sensitization. So now everything just hurts. So the more of that pain just drives more inhibition. And you can actually see this in those with patellar tendinopathy. They do have altered landing mechanics. And a lot of this is that decreased knee extensor torque. So if you're not producing force in the quads, you're not going to produce that much knee extension torque.
And then you can't land correctly, and then you can't fix your patellar tendinopathy.
Then it gets worse or comes back. See? It's a vicious cycle. You can also see reorganization of the motor cortex as a whole. So now your whole motor cortex is just changing to try and accommodate this and try to protect the area. Areas that in the motor cortex that shouldn't be active for some reason are active. And this actually creates just a lot of inefficiencies in the brain. And the brain does not like inefficiency. It wants to move efficient, as we all do. And this is kind of seen throughout the chain, right? You start to see decreased external rotation strength and hip abduction strength, like you said, right? Because especially with that decreased
glute,
decreased glute because of the decreased ankle dorsiflexion.
Yeah.
Right?
So like we have multiple channels saying glute turn off.
Yeah.
Which means I think you know where we're headed with this.
Yeah, with the rehab.
Yeah.
Absolutely. And there's some limited evidence that has shown that our just postural stability, just being able to balance, goes out the door with patellar tendinopathy. And so again, the whole motor system is changing how it's working. Inefficiencies could lead to that. Muscles being overactive compared to underactive could do that. Right? So basically your motor system's like, I don't know what I'm doing here. I'm drunk, go home. So like you said, we know what we can target. We know what we can attack with patellar tendinopathy.
Are we ready for interventions? Because I've been ready.
Yes.
I'm so ready.
So as our goal with any tendinopathy, and especially in the literature, the focus is, okay, we need to load the tendon, right? If we load the tendon, it stimulates the healing process. And eccentrics for the knee, for patellar tendinopathy, continue to be kind of that first line of treatment. But as with like Achilles tendinopathy that we've seen, there is emerging evidence that heavy loading can also be very beneficial, right? So you don't have to necessarily just blow them up with eccentrics. You could do heavy concentrics or heavy isometrics.
We love isometrics for tendons.
Yeah, and honestly,
especially in the beginning.
Yeah, I was going to say, this is actually where the isometrics, like patellar tendinopathy, isometrics became really popular for tendinopathies because of, I think, the patellar tendon. There were two really good articles that came out, I think it was around 2016 time, around there, that really started to show like, hey, you can do this in season. It's not that crazy. It doesn't create a lot of discomfort, but it decreased their pain. And now everyone kind of started jumping on board on, whoa, maybe isometrics could be a thing. That, at least in my circle of friends, that's what it was. We're just nerdy, so.
Isometrics could even be like your basketball athlete who's doing like a 60-degree single leg squat and you're passing a ball back and forth. Yeah.
Ooh, that's good neuroplasticity work right there. Dual tasking.
Dual tasking. Or what I like to do is some of the dual tasking. We have posters up on our cabinets. And so I face them toward the cabinets and then I have them read the posters forward and then read them back, like word by word backwards.
Ooh, that's cool. That's hard.
And then they don't need necessarily me. Like I'll be there, but like they can also set it up themselves and like do own. It. Because like also like you can do like your serial sevens where you're like, okay, like count backwards by 7. Like I'll actually, I think that's sometimes hard, especially for like my population. So I'll start by like, okay, count backwards by 2s, count backwards by 3s, count backwards by 4s, and then kind of like build up.
Yeah, build up.
I don't just start at 7s. I mean, I know it's supposed to be difficult, but like we don't have to like blow them up. We still want them to come back.
Yeah, I'm gonna need you to solve the Pythagorean theorem while you're doing your balance for me.
Right.
These things.
Right.
But yeah, no, that's awesome. And the neuroplasticity part is really good too, because that's how you get those adaptations too in the motor cortex. Is through that. Along the lines with those heavy loading has actually been shown that there is some support that it might be better than eccentric exercise, right? So it's not only possibly more comfortable, but it could actually be possibly more beneficial. That's still to be determined. And maybe you start with that, and then as they get better, then you throw in the eccentrics, right? There's a lot you can kind of tailor this to. Again, isometrics are definitely being explored, and there is very limited support on that. Hey, it actually can be very beneficial in isolation. I think a real world application and some of the progressions I've seen is that you start with the isometrics, right? Once they start getting some improvements, then you go into, hey, maybe go into heavy load concentrics, or maybe jump into your eccentrics.
I think one of the biggest things, like you're doing isometrics and stuff, and obviously glute is so important. But doing these things and making them stick somehow. So like you have to be able to get their brain to translate that to the field, to the court, to wherever they are doing their activity. And I think that's why this dual tasking is so emergent.
100%.
And how it is kind of the new place of rehabilitation. Another thing that we talked about in our doctorate program in neuromechanics was, I am blanking on the word for it, but where you kind of reteach like a motor pattern, I guess. So with patellar tendinopathy, when they are not firing their glutes enough, but they're maybe firing like quads too much, we want to focus on like maybe you can stim the quad or you can ice the quad and then do like glute activity or then do core activity and kind of re-pattern their brain in, hey, I need to use my glute more.
Yeah.
Like, yes, you can have, and I explain this to them, like you can have the strongest glutes, but if they are not turning on at the right time, then it's not being protective of anything.
For sure. And I think, again, that's why when you look at studies that look at strength as a risk factor for injury, I think that's why you get such mixed results, because all a strength measurement is, and strength in general, is how much force can you produce at one time. But that is not how sport is.
And that's not how we walk. That's not how we run.
Exactly. We need controlled strength. We need timing of strength, timing of activation. So I think,
like if you even like going back to hamstring, like if you look at when someone fires their back extensors versus their glutes versus their hamstrings, and like after injury, their hamstring fires so much quicker. So when you're looking at these things, like it's not necessarily just about that strength.
Yeah. No, yeah, exactly. 100%. And I think, again, that goes back to like what we said with patellar tendinopathy. The prognosis long-term of patellar tendinopathy is they tend to still have deficits. I mean, there's studies that have looked 4 years down the line, 5 years down the line, and there's people that still somewhat have symptoms. And I think that's part of it is
it's their entire movement patterns, how they move.
How much did their initial rehab, like, because again, a lot of these studies only focus on that one intervention, but that's not real practice.
Right.
You're not just going to show up. Hey, we'll do an exercise. Okay, bye. Have a great day. Right. We're going to do a combination of things, and hopefully we're treating the deficits that we see, hitting glutes, working on that ankle range of motion, if that's truly what we're seeing in that person. So could that make a difference on hopefully kind of making the long-term outcome of patellar tendinopathy better?
Right.
I think that could be the limitation on why there's still those reports that, hey, this tends to last a while. Well, if we're not addressing the inhibition, the just jacked up motor system, it's going to come back.
Right.
So I think that's a good point.
Right. And I think that's a huge education piece for the student athlete or patient, whoever you're working with, is this is going to take a while, and you're going to have good days and you're going to have bad days. It didn't occur overnight unless you have like a patellar tendon strain, but like patellar tendinopathy does not occur just overnight. It has been breaking down for a while, so we have to repattern your brain and repattern your body to actively work consistently in the way that is pain-free,
for sure,
so that we can get you better.
Yeah, I think that's an important thing, because I love it when kid comes in, has had, in this case, knee pain for years, and all of a sudden it's like expecting that it's just gonna like comes in like it's just gonna go away.
Yeah. Well, you didn't help me.
Dog. It's been years. You think I'm gonna break a pain cycle and just all that in like a day?
One of my favorite patellar tendinopathy return to plays was one recently who even like he got PRP and like all, did rehab extensively through PTs through like lots of different interventions, and the thing that ended up working for him was ice on his quads to disrupt the quad pattern of just like overactive quads. Disrupt the quads with the ice. So basically we're going to do cryokinetics a little bit. And then go straight into glute exercises, full body with a focus on glute. Do that dual tasking so it translates to the field. And then he was able to run like receiver. He's able to run, jump, sprint, cut, and really. So before games, he would do the 2 ice packs before his on his quads.
That's interesting. That's cool.
And then that would be the thing that really helped him get
awesome.
to like that remotor pattern.
Yeah, that's really awesome. Nice. That's cool. Yeah, I try to tell them too, because I feel like my basketball guys, right? Like, what did you have to do to get to like where you are in basketball?
Oh, this is good. This is good.
Oh, I had practice. So you didn't just like show up to the gym one day of practice and instantly be where you're at.
Natural.
Yeah, right? So why do you think that's going to be the same for your years of knee pain?
That's really good. I really like this.
That I could just show up for one day of treatment like, oh man, I'm all of a sudden better. Like,
right.
It doesn't work that way. Just like athletics doesn't work that way.
Right. Just gotta reframe it.
Kids. Yeah. The last thing outside, there is actually a little more that we can do with patellar tendinopathy, and that could be the patellar straps.
Oh yeah.
And there actually is surprisingly a good chunk of research that has looked into it. I don't know why that surprised me, but it actually has been shown to show some benefit in pain. You can actually have a small decrease in pain, and with that, there might actually be a slight improvement in like balance and postural stability. So the patellar straps actually can be beneficial. It's not just like mindset.
It's like
maybe it is, but
if you just held it the entire practice.
Yeah. Right. So that is actually a tool. So again, like if you're looking for things that like I have a limited budget and I don't know what to buy, that could actually be one thing that like there's actually evidence that shows, hey, it does actually have some benefit.
More than placebo.
Even though placebo is still important.
It is.
Right. If someone feels like it made them better, then right, it works for me. If you felt better.
Yeah. That's our goal here.
Yeah.
Well, do you have an action item for this?
Yes, I do. Action item is going to be don't land too stiff or uncontrolled, and really address the entire motor system when you're working with someone. Think of the full chain when you think about patellar tendinopathy.
I love this like motor system and nervous system and like how we are not just our profession, but like other professions are also, I feel like you hear about it more. I love when the brain talks about the brain. I think it's so cool.
I mean, that's literally what it is. It's brains talking about brains and trying to understand itself.
Yeah.
It's crazy.
It just goes back to like the why.
The why.
You got anything else on this?
Nope.
So we do have this available as a CEU, again, category A. Thank you to Clinically Pressed and Athletic Training Chat. Go down to our show notes to find the link for the CEU, and you can roll in the course, watch the video, which you're watching right now, and then take the quiz, course evaluation, and
get your CEU.
Get your certificate automatically generated. If you want a little video, we have one on our Instagram, and we also have other episodes on the show, not just CEUs. So we do story episodes where we bring stories from athletic trainers from around the world. We're currently putting together one on imposter syndrome. Thank you to a listener request. So we will be putting those up on our Instagram stories soon if you're interested in submitting your story on imposter syndrome. We also have interview episodes. We have so many more in store for the spring, second half of this season. So stay tuned for those. If there's anything else you need, feel free to reach out. And I think that's all I have.
Thank you for helping us showcase athletic training behind the tape. Bye.